So I think the coordinator, today's web coordinator is Bijendra, is going to tell us, something about the program, and we'll be starting, and we hope to finish by 2 hours, I think. Okay.
Thank you, sir.
Bijendra.
Thank you, sir. Respected professors, seniors, and dear friends, very warm good morning to you all. Hope and wish we all are in a good health. On behalf of Arthroscopy Society of Nepal, I would like to welcome you all in ASON webinar. In previous webinar, we had learned about the graft harvest techniques, where we discussed about the BPTV, quadriceps, and peroneus longus graft. Today, we will be focused on hamstring graft, as it is the most common graft used in the ligamentous reconstruction around the knee. We will be discussing about the various advantages and the disadvantages of the graft, starting from graft harvesting to its management technique to ligamentization of physiotherapy protocol as per stage of graft healing, and we will be having a 2 real-life surgery too. So on behalf of Arthroscopy Society of Nepal, I would like to thank all our eminent speaker, Dr. Vivek Vasukala, who will be speaking on the ligamentization of hamstring graft. Nijan Bajacharya, he will be talking about the physiotherapy protocol as per stage of graft healing. Dr. Selaj Ranjitkar sir, he will be talking about the how do I harvest hamstring graft by the real life surgery. And Dr. Ishwar Pradhan sir about the graft management in the real life surgery part 2. So with the due permission from our President of Arthroscopy Society of Nepal, Dr. Ishwar Pradhan sir, I would like to start the webinar, and I will request our first speaker, Vivek Vasukala, to share his screen and start his presentation without any further delay. Vivek, are you ready?
Yes. Thank you, Bijendra. Is my desktop visible?
Yeah, it's visible.
Okay. Give me a minute. Okay. Bijendra, am I audible? Bijendra?
Yes, fine.
Vivek, you are audible.
Okay, I'm going to start. Respected seniors and colleagues, today I'm going to talk about a very important topic, not so interesting topic, I must say, but very important topic. It's called ligamentization of hamstring graft. I'm Dr. Vivek Basukala. I work in AKB Center for Arthroscopy, Sports Injuries and Regenerative Medicine, BNB Hospital, Guarkola Lalitpur. So whenever there is tear or there is absence of any ligaments within the knees, right? What we do is we reconstruct or we replace that graft with some other graft materials. The graft materials that can be used are hamstring graft, bone patellar tendon bone graft, peroneus longus graft, or quadriceps graft, all of which we have discussed in previous webinar. But today we are going to discuss about the hamstring graft. And I will be discussing about how this tendon becomes ligament. That is the process called ligamentization. So this is how we harvest the graft. After the graft is harvested, a very important step is graft management. We do duplicate, triplicate, quadruple, pentaple, or hexaple the graft. Then get the adequate length and size of the graft and insert that graft into the intra-articular region, into the tunnel we created with the help of arthroscopy. So we might think that after doing this, after doing good reconstruction, after getting this shiny new ACL that is visible on arthroscopy, our job is done. But actually it incites or it initiates the process, very complex process, through which this new graft becomes a new ligament, new ACL, and that process is called ligamentization. And Bijendra?
एकछिन है म गरिरहेछु
Okay. So this complex process from because of which this graft becomes, the tendon becomes ligament, is called ligamentization. And this term was first coined by Imel et al. In 1986. But this ligamentization or graft healing process constitute of two parts. That is the healing process that occurs in the articular graft, the graft which is in articular surface, articular area, and those graft which resides into the tunnel. So I'll be discussing about various changes that occur in this articular graft and tunnel graft. So whatever we be the process, our aim will be to have the graft uh, like this, the well vascularized, well synovialized graft, which is very much indistinguishable to the original ACL. But this is not always the reality. We can have the graft like this, the partially synovialized, and with some laxity. Sometimes the graft may be as bad as the healing of the graft may be as bad as the below pictures. So not all graft heal as we desire, and this healing is called the ligamentization. We'll be discussing about this. So this picture clearly depicts what ligamentization is. The ligamentization actually is the adaptation of the body because of which the tendon becomes a ligament. This is just like a tropical bear converting into adapting into the polar bear while it starts living in the polar area. So this adaptation follows the rule of Davis law. This is Wolff's law equivalent of soft tissue graft. According to it, whenever there is stress in some direction, the ligaments, the collagens and various ground tissues are laid down upon there, and wherever there is no stress, the collagens and various ground substance are not laid down upon there, because of which the morphology and characters of the structures within the area changes. And according to Davis law, it also states that the double bundle ACL reconstruction, double bundle, even single bundle ACL reconstruction in due course of time will behave like double bundle because this Davis law. Okay, so this all process is called ligamentization, as I have already mentioned. There has been multiple studies about various stages in this ligamentization, and there has been animal model studies in animal model and human studies. The best one is the biopsy studies. And in animal model studies and human studies, there have been described three different stages of ligamentization, which are termed early, remodeling, and maturation. We'll be discussing details about that. This is very complex topic, so I have tried to make it simple by comparing our ACL or any graph with this building. Let us compare the ACL with this building. ACL has been ruptured, the building has been collapsed. So what we must do is we have to reinstate or reconstruct this building, reconstruct the ACL. To reconstruct that building, we have to have a good supply of the building materials, and that for that we need the highway or we need the transportation. So this highway or transportation function is carried upon by the blood vessels. So immediately after the graft has been inserted into the knee, what happens is there will be increased vasculature mainly over the surrounding of this new graft. Then what happens? You need to have good manpower, you need to have good laborers who will work in this construction site. And accordingly, these laborers in our body are the fibroblasts and various cells. So cell population will increase immediately after the graft is inserted into the knee. And after that, what happens? The workers will lay down various frameworks, various pillars into this building, into the framework, thus making the framework or framework over which various substances are added like RCC and cement, which will finally make a building. Similarly, in ligaments, in grafts, what happens is these workers, that is the fibroblasts and various cells, lay down the various types of collagen, which acts as a framework over which the ground substance and proteoglycans are added, thus leading to conversion of the tendon to the ligament. So initially what happens everywhere, whenever the work is started, there is chaos, there is not so much of the array, there is of most of this array, and gradually the system, and gradually the alignment takes place. Similarly, and it comes to some shape after after some time. Similarly, in our ligamentization stage also, early stages are characterized by deposition of the ligament, the collagen and cells which are not well aligned, and later on gradually they are well aligned and forms a final good ACL or final good building. So let us talk it in this picture again. This is the knee where ACL has been gone. We do the toenail preparation and keep the and insert the graft. So this graft, we'll be more focused about this graft, and this graft can be divided into graft which is in articular surface and the graft which lies into the toenail. So we'll be more, first we'll be talking about graft which is in articular side. Early phase is characterized by increased vasculature, increased number of fibroblasts and various cells, but characteristic feature in early phases, these are not well aligned. The angle, the orientation are very random in early phase. And what happens is because of peripheral vasculature, the vascularization is more at the periphery. So central vascularization may be very less, leading to some necrosis at the center of the graft. Another phase is the remodeling phase, characterized by decreased cellularity, and the cells now are well aligned, and they are well well aligned at this time. Gradually, they lay down the collagen materials, and collagen materials are further strengthened. The crimp in the collagen develops further, and various ground substance, right, proteoglycans, and all are deposited, leading to final maturation. So this is various steps in ligamentization. So how do we assess the ligamentization process? The ligamentization can be assessed with three techniques. First one is the biopsy of the graft after about few months, like 6 months or 1 year. Second is non-invasive procedure like the MRI, and third one is the second look arthroscopy. Various studies have been published on all three aspects. This is the slide I have already mentioned, and this is very important slide. Almost all ligamentization paper quote this paper published in AJSM by Claes et al. According to them, there is three distinct stages of ligamentization: early, remodeling, and maturation. And various researchers have mentioned various time duration of these stages, but the consensus is the remodeling stage starts later compared to animal model in human, and usually by 8 to 12 weeks the remodeling process starts. So by 8 to 12 weeks the graft is strong enough, and graft is more of the ligament than of tendon. This is another study. Um, this is also a systemic review of various literature published on ligamentization, and this also favors the study by Claes et al. And according to this paper, the vascularity, cellularity, and fiber patterns continues to increase even after 1 year period. So ligamentization, the process of ligamentization may take up to, complete ligamentization may take up to 2 to 3 years time. So this is a paper that shows how the ligamentization are judged according to the MRI, and they use the Figueras score criteria. The details of all the details of which is out of scope of today's talk. Another is the grading of maturation or graft ligamentization by second look arthroscopy, and much has been published in this regards. And these all things can be summarized into four terms, that is integrity, graft integrity, tension, synovialization, and vascularity of the final graft. So out of all these four things, integrity and tension were positively correlated with clinical outcome finally, but synovialization and vascularity were not clinically significant. But as you all know, if the graft is not well synovialized and well vascularized, there is always a risk of future failure in these particular grafts. So let us now talk about the changes that happens in graft bone interface. So to understand this, we have to first understand how ligaments gets attached into the bone. The ACL and PCL gets attached into the bone. Usually in our human body, the tendons and muscles get attached to bone with the help of the surface fiber, but it is different in case of ACL and PCL. ACL, PCL gets attached directly with the help of the direct fibers, and there is clear distinction, gradual distinction from tendon to bone through tendon, mineralized fibrocartilage, unmineralized fibrocartilage, and bone. So the attachment of normal ACL to bone is very different from attachment of other structures, other soft tissue structures into the bone. But this has not been replicated till today with our usual reconstruction. And what happens is after the tendon graft has been inserted into the tunnel, what happens, the tendon bone interface is uh, covered by the granulation tissue. This is the early phase that lasts up to 4 to 8 weeks. There is um, granulation tissue, and this granulation tissue is filled with multiple hypercellularity. So this is the histological picture in first 4 to 8 weeks. And then follows the early phase, which is characterized by formation of surface-like collagen bridging this interface. These are the bone, and this is the tendon area, and these are surface fibers that bridges the bone and tendons. Thus, more the number of these surface fiber, more the strength, pull-out strength of the tendon or the any graft from the bone. So these are the basis by which the our graft finally heals with the bone. And these start usually after about 6 to 8 weeks. These surface fibers are not new thing, as I have already mentioned. Any tendons in our body, even the dentine structures or ligaments or the tendons gets attached to the bone with the help of the surface fibers. So to have the good graft tunnel healing, to have the good graft strength, or to have the good strength of that graft, you must have good graft tunnel healing. And there are various challenges at the graft tunnel healing. The first and foremost is presence of inflammatory cells at the interface. As we all know, inflammation, the more the inflammation, more the scar tissue, and the scar tissues are not so strong tissue. So if the graft heals by the scar tissue with the bone, rather than the surface fibers, what happens is it is usually weaker. So the more inflammatory cells is usually the challenge of good bone tunnel healing. Second is slow and limited growth, bony growth into the graft at the bone tunnel interface. Third one is usually these grafts and these tunnels has less number of stem cells at the healing site. And because of early rehab, we aggressive rehab we do in ACL reconstruction, PCL reconstruction, there is some graft tunnel micromotion, and the healing may be hampered because of this. And finally, it is a very different technique. It is different ACL formation than the embryonic ACL formation. So lack of good coordinated gene signaling cascade may lead to not so good graft tunnel healing. So according to Noyes in his famous textbook, there are various techniques to modulate these factors to promote graft tunnel healing. He has uh, divided this into technical, biological, and mechanical factors. In technical factors, according to him and by various research, longer the tendon longer the length of the tendon in the conine, longer the more the surface area of bone and graft healing, so more the chance of good graft tunnel healing. Another thing what we can see is we can make the press fit graft. That means the size of the tunnel and size of the thickness of the diameter of the graft, if they are matched so as to get press fit, there will be less granulation tissue in between the graft tunnel interface, thus leading to good graft tunnel healing. Another, they mentioned that if we use suspensory fixation in place of the uh, interference screw, this will lead to increased graft and bone contact, thus leading to increased healing capacity. Another is biological factor. In biological factors, if there are anything that can suppress inflammation, that will lead to uh, good scar or good surface fibers formation. But measures to decrease inflammation by use of NSAIDs has not showed good results. Another is bone ingrowth. If we can stimulate bone ingrowth by injecting bone morphogenic protein or any calcium supplement within the tunnel, that has shown to be good for good graft tunnel healing. Even injection of stem cells and measures to increase vascularity has resulted in good graft tunnel healing um, after the graft is inserted. And another mechanical factor is graft micromotion, and Dr. Nijan will be talking about this, I think, in detail. And according to them, good period of rest after the physiotherapy uh, will have will decrease the graft micromotion and will lead to good graft tunnel healing. So graft tunnel healing can be assessed with the help of MRI, and usually Howell criteria are used, and these are graded into grade 1 to grade 4. We can get and grade 1, grade 2, grade 3, grade 4 are categorized according to the signal of the graft that we get compared to the PCL or the patellar tendon. So what was the result or conclusion of this paper was the graft tunnel healing was better with suspensory fixation than interference fixation, as mentioned by Noyes in his book. And we made there is a trend toward the remnant preservation in today's world, today's arthroscopy practice. And according to this paper, if the remnant is very important, but those remnants which are not well synovialized, the preservation of those remnants may not be more helpful in good ligamentization. So synovialized, well synovialized, like type A and type B in picture A and picture B, these are the remnants which must be preserved. Rather, the type C and type D remnants, they may not have so much role in ligamentization per se, but these, as we all know, remnants are very much helpful, very much important for the proprioception and various other things. But for ligamentization per se, these non-synovialized remnants are not so much important. So what are the techniques that leads to enhancement of graft tunnel healing? There are various things mentioned in literature, like Swiss roll, bioactive hybrid, various type of scaffolds, with use of mesenchymal stem cells injection. Even injection alendronate has found to enhance the graft tunnel healing, and use of suspensory fixation in place of interference screw fixation has also led to increased graft and tunnel healing in the literature. So this is out of scope of today's talk, but I thought I have to give it a mention because BPTB is also frequently used. And what Noes has to say is the healing of BPTB into the tunnel is by earlier by osteonecrosis followed by creeping substitution of the host bone, but healing at the aperture, which is the most important thing of graft healing, is again by the tendon to bone healing. So good ligamentization, good tendon to bone healing, good surface fibers are important even in BPTB. So take home message is ligamentization is complex procedure that transforms the graft from tendons to ligament, and there are different processes that happens in tunnel and articular graft. Early phase is ends at about 8 to 12 weeks, and at this time the fixation at the tunnel depends more of the fixation method. This is the weakest link. So and so physios should be tailored accordingly, and end stage of ligamentization is at about 2 to 3 years. By the time when if the graft is taken and seen in light microscopy, it is indifferentiable from the native ACL. But ultrastructurally, if we see by electron microscopy, they are always different from the native ACL. So we can never replicate the native ACL uh, ultrastructurally, but rehab has to be tailored according to the ligamentization. So finally, uh, our body, human body is very good machine. It leads to ligamentization of metamorphosis of this hamstring tendon into the good ACL graft. Thank you.
Congratulations, Vivek, for your well illustrated presentation. It was really a nice one. So, is there any question? If there is any question, they can unmute themselves and ask question.
I think there are no questions, Bijendra.
छैन सर के पनि यो च्याट बक्समा
Bijendra?
हजुर सर
Yeah. Okay, Dr. Vivek, very
Yes, sir.
good illustrative presentations. As you mentioned in your presentation, also is a controversial also. As
Yes,
you
sir.
said, this a sling, the aperture cortical fixation has got a better healing potential or the vascularization.
Yes, yes, sir. Ligamentization.
Okay, if we see like it's like it is compared to the fracture fixation with the loose implants. If the fracture fixation is very rigid, the healing occurs early. Like that, if there is a cortical fixation, that can also lead to some bungee jump effect and the bungee effect in the aperture. That can lead to even widening of the this tunnel, they say. But how come this ligamentization is like early, the better with this type of fixation rather than the aperture fixation?
These two graft effects, the bungee cord effect and windshield wiper effects, are both common both with suspensory fixation and the aperture fixation. But we are concerned in this talk more about the ligamentization, and according to various literature, what they mention is the more you give the surface area to heal, the more good the healing is. That means if you use the aperture fixation with the interference screw, what happens is almost about half of your space is covered by the screw. So only half of the space is remaining for graft to heal with the bone. So that is the whole principle why the graft tunnel healing is good with the aperture fixation. Coming to your second part of the question about the dilatation of the tunnel after the suspensory fixation, and literature says, I think the graft tunnel motion micro motion is most the maximum at the aperture, and it is least at the exit point. So if we can do press fit, the graft tunnel micromotion can be decreased, and this is prevalent both in suspensory and the aperture according to literature. So I think it's good to use the suspensory fixation, and we are changing, the world is changing towards this suspensory fixation because of these all factors.
I just want to add, like also what Arjun was pointing out, first of all, Vivek, it was an excellent presentation. You did justice to the topic by presenting yourself. There are a lot of new things, not new thing, but a lot of things it's a very difficult topic, and understanding ligamentization as well as tendon bone healing is very difficult. But the book written by Noyes is a very fascinating, he has done an intense, deep study about this tendon bone healing as well as ligamentization. What I understood by your presentation as well as some of the studies I had done was this healing of tendon and ligament, healing of tendon into the bone, and then the ligamentization that occurs in the intra-articular part is a very complex thing, It's a balance between what Vivek pointed out, it's not just one factor that you can say that is going to heal, there are multitude of factors, as Vivek said, the area of the tendon that is exposed into the tunnel, and how press fit you do. It's not just, if you have a good length of tunnel in the tibia as well as femur, where the area of the tendon is exposed, but if you do not have a proper press fit, then you definitely land up with other problem. But then again, if you use a aperture fixation like interference screw, then you will be decreasing the exposure of the tendon to the bone, and that will have a negative effect. On top of that, the tension you put, your post-operative protocol, if it is too much, that may also be an effect of what Arjun was saying, causing that dilatation of the tunnel. So it's a very complex, intermingling, interrelated healing process, part of which we still also don't understand, but some we are trying to understand. I think it was a very, very nice presentation, if that sense, Bijendra, I think we should go on.
Dr. Ishwar, I want to have one question. Yeah.
Yes, sir.
Hello? Dr. Vivek, that was really very elaborative and comprehensive topic presentation. Congratulations to you. My question is like you mentioned that only those, we are talking about the graft preservation. You said only those graft which is covered with the synovium, the type 1, type you showed, only they are significant as long as when we want to preserve the graft. But I don't know, in my practice, or maybe I would like to know those who are, you are doing a lot of cases, 90% of the time, I don't see synovium covering those remnant grafts. So if we follow this theory, how often we are justified with the remnant preservation when we really don't see those synovial covering grafts? So
Agreed.
yeah.
I have mentioned in my talk as well, while we talk about ligamentization, good ligamentization, that good ligamentization means good synovialization, good vascularity and everything. For that purpose, type 1 and type 2 remnant. Type 1 and type 2 remnant means more than 50% of graft, the remnant is synovialized. For ligamentization per se, those type C and type D, less than 50% synovialized remnants are not so much of help. But as we all know, these remnants contains various neural structures like Ruffini's corpuscles and Golgi organs, which are very helpful for future proprioception and all. And that has been proven by multiple studies. And as I have already mentioned, the second look arthroscopy for ligamentization, what they have seen is integrity, then the tension, vascularization, and synovialization. And only clinically significant things were the integrity and tension, not the synovialization and vascularity. Whatever the status of synovialization and vascularity, those were not clinically replicated. So I think it's good at this present moment to preserve as much as remnant as possible so that we will get some benefit of proprioception and neural supply.
Okay, thank you.
Vivek, let me add to this because we've been working a lot in remnant preservation. We have to understand that you are using a tendon to replace a ligament when you are using a graft. So the best principle of preserving the remnant is you are preserving the ligament, which eventually does require ligamentization. So if you preserve the remnant, which is itself a ligament, so a ligamentization process of the preserved structure will not be required. Only that part, am I audible?
Yeah,
only that part of the ligament, that part of the replaced or the reconstructed ligament will undergo a ligamentization, number one. So if you can, and there are a lot of study which is saying that there are various types of, remnant which is attached to the femoral condyle, which is attached to the, the PCL, which is attached to the floor of the tibia, and these all remnant have certain property of stability. And there is a very nice research which showed that in some of their cases they have removed the remnant and checked the stability, and other group in which they have preserved the remnant, and that means before removal of the remnant and after removal of the remnant they have checked the stability before doing reconstruction. So this indicates that these remnants provide certain degree of stability also, and then definitely will act as a biological splint for the graft that has been done. And then there are a lot of research going on remnant preservation, and the one and most important biological advantage of ligament preservation is it doesn't require ligamentization, and it preserves most of the sensory apparatus. The proprioception is preserved so that the rupture, the chances of rupture is very less. Another thing, I don't know, I may have missed. that these ligaments heal at aperture. So how long you put, there is a paper by Bancha, and the Bancha very much used to emphasize that the healing takes place at the otis or at the aperture, not at inside. The inside is all fibrosis, so the surface fibers are formed at the aperture. So probably all the healing will take place at the aperture. So we have to identify that your ligament is very, very press fit, and then it is very press fit at least at the aperture, so that you can have a good healing at the aperture. Thank you, Vivek. That was a good presentation.
Thank you, Mr. Vivek.
Vivek,
Yes.
I have one query.
Okay, Sushil.
After ACL reconstruction, most of the surgeons, including myself, were tempted to perform Lasman test after a few days or few weeks to find out how the ligament inside the tunnel is working. And there are again discussions that say that we are not supposed to perform Lasman test after reconstruction because it causes laxity of the ligament. Is there any step in the ligamentization process that suggests that because of this reason, you are not supposed to perform the Lasman test or anything like that, Vivek?
Very interesting question, Sushil. This is very practical thing. I think when I went through the literatures of the ligamentization, what I found was for first 8 weeks, there is good change that happens in the articular sided graft and graft which is inside the tunnel. So what happens is in articular sided graft, there is increased vascularity, and the vascularity is more at the periphery. So it is a sort of centripetal supply, because of this centripetal supply, the central about 1/3 to half part will be necrosed. And this necrosis is very much shown, very much proven in animal studies, but in human studies, because all the graft from total graft cannot be removed for biopsy. This has not been shown so much vividly as in animal studies. But there was one study in which the whole of the graft was removed after the death of the person. And in that graft, the central necrosis was present. So central necrosis do occur in human graft as well. So for first 8 to, I think, up to about 12 weeks, it's not safe to do the various maneuvers like ligamentation and pivot shift test according to the ligamentization process. Also, the healing at the graft and tunnel interface, the good surface fibers develop at the time of about 8 to 12 weeks. So up to that time, you are all dependent upon your fixation devices. So these may fail, and this because of all these things, I think the various maneuvers should be reserved up to about 2 months. I think Nijan in his talk may include this thing as well. So for me, the various maneuvers for about 2 months is no, strict no.
Okay, thank you.
Dr. Vivek, hello, Dr. Vivek.
Yes, yes.
Yeah, theoretically, yes, but many times, many of the lectures, I have seen people say ki after your ACL reconstruction, then you do the pivot shift test, and
Yes, that is true.
just to show
Immediately,
that, yeah,
yes,
whether your fixation is right or not. Then
yes.
you mean to say we should be avoiding all this kind of tests?
No, sir. On table, we have to do pivot shift test to see whether we have the pivot shift that was present before reconstruction is relieved or not. But I'm talking about the later stages, like 2 to 3 weeks time, when the patient comes to follow up in your OPDs. At that time, the graft undergoes stages of necrosis and it's very weak. So I think at that time, the pivot shift and various other tests should be deferred. Not at the on table. On table, we can do it.
I think there was a this is a very practical and interesting question. But you see, if you have done ACL reconstruction yourself, you know that your ACL, after ACL reconstruction, you know that you have seen that ACL is very well reconstructed and it is very well fixed. And unless patient has some problem, either he gives a history of trauma or history of instability, or why should we examine up to 3 months? Why should we
Yes,
examine the pivot shift? Probably practically there is no use of examining unless some patient have some feature of instability or the feature of some re-injury. I do not do pivot shift test and usually ligament test until 3 to 4 months time. Only after 4 months, if the patient complains something, then I gently do a ligament test. And another thing is, Vivek very nicely mentioned that the ligamentization process starts after 12 weeks. So it is a 3 month. And your ligament weakening starts after there, after about 6 to 8 weeks time, your ligament starts weakening. So up to 8 to 12 weeks, it is all stability by the ligament strength and the fixation devices one. So probably looking at these literature also, gentle doing a Lachman in early stage is possible, even in intraoperatively, it is possible. Probably in the later stage when you have to, abstain from the doing all these tests.
Thank you, Vivek. Already you have answered all the questions, but there are a few questions were in the chat box. I think we already have discussed about that thing. If you want to add something, you can add in the chat box only, as we are getting out of the time. So I will request another speaker, Nijan, to share his screen and present on the physiotherapy protocol as per Graft staging. So Nijan, are you ready?
Yes, sir.
Okay, you can share the screen and start presentation.
So my screen is visible.
Yeah, it's visible and you are audible too.
Thank you, Dr. Vijendra, respected doctors and the professor, and a very warm welcome as well as a good morning to one and all. Today I'll be talking about the physiotherapy rehabilitation as per the stage of graft healing. So the main purpose of the rehabilitation is to get back to sports and aerial activities as soon as possible by protecting the healing graft. How we can achieve it? How we can achieve our target and the purpose within a time by normalizing the gait pattern, working in a proprioception, and a total fitness. So when we talk about the rehabilitation, we rather divide the rehabilitation on the basis of different phases than that of the time basis. So when we incorporate rehabilitation phase with the graph healing stage, it can be classified as early graph healing phase, immediate post-op, and the early rehabilitation phase. In proliferation phase, a part of early rehabilitation phase, and progressive strengthening and neuromuscular control, remodeling, and the maturation stage, in which the advanced activities phase we will be working on the power training, plyometric exercise, and the agility. So when you talk about a hamstring graft, there's a special consider we need to take care of when we are rehabilitating the patient. So I'll be talking first about the special consideration, then I will go through the throughout rehabilitation process that we have been doing. So the in early graft healing stage, we do not allow the active heel slide up to 3 weeks. It is to protect the donor side, that is the hamstring donor side. Also, the hamstring stretching is not allowed up to 3 weeks. And during this phase, we try to maintain the length of the hamstring. The safe exercise during this phase are isometric quadricep and the glutacet. We will begin the close-in exercise after 3 weeks, such as the leg press and the quadricep within the range of 20 to 30 degrees. We incorporate close-in exercise as it helps to facilitate the gluteus muscle as well as thigh muscle, which helps to align the knee and protect the ACL. The study has shown that in open chain kinematic study, the ACL graph is loaded more in between the angle of 50 to 10 degrees. So when we begin our exercise program, the initial open chain kinematic exercise is given within the range of 90 to 60 degrees so that there is no place on the graph. So during the proliferation phase of the graph healing, the isometric exercise is progressed to isotonic exercise with the help of resistance, and the hamstring curl is begin only after the 4 weeks, and the progressive resisted hamstring curl is begin after 6 weeks. Seated resisted flexion exercise can be started after 6 weeks. By this time, there is a proper healing of the donor side. So the flexibility as well as the mobility exercise of the calf, gastrocnemius and the hamstring can be started. So we'll be begin with the calf raise exercise. There's double leg raise, which is progress to the single leg after the 6 weeks. So from 6 weeks to 3 months, the hamstring uh, gets incorporated to bone within 8 to 12 weeks. The study has shown that by the time of 6 to 8 weeks, the graft is at its weakest point. It is because of the decrease in the mechanical properties and the grip of the graft. So during this phase, a controlled loading should be given. The control loading exercise should be given so that we can enhance ligament and tendon. So if you are providing the excessive stress and load to the graft, it causes the elongation, leading to the unwanted anterior posterior laxity of the graft. So the progressive resisted isotonic exercise will still be doing within the range of 90 to 45 degree, and the few exercises will be adding during this phase, such as breathing, double leg breathing to single leg, stepping up, down with the variation in height, repetition in speed, as well as a various type of lunges. There is forward, backward, and the lateral lunges will be initiated. During the phases of a remodeling and a maturation stage, the high level exercise, that is a progressive resisted exercise and the neuromuscular control will be progressed. Jogging, hopping exercise will be added. Core exercise will be more emphasized, whereas a plyometric and a sport specific exercise will be given. So when we begin the rehabilitation, we have to take care of different things. We have to look in a different area from the start to the end of the rehabilitation. The area of where we more focus are no trick contraction, pelvic drop or hike, excessive arching, flexion of the back, and the genu-valgum when we are performing the exercise, such as the lunges, forward lunges, split squat. We need to prevent the genu-valgum of the knee and the kinetic change of hip, knee, and the ankle. So immediately after the post-op, IC is a best choice for reducing the swelling as well as the pain. CPM we do not use nowadays. Stimulation after the uh, after the ACL reconstruction, if there is a quadricep inactivation or the activation failure, we give stimulation to the quadricep muscle for a couple of days, and it will be stopped once there is a good control of the quadricep muscle. Rest in case of patient complaining of the pain, it is better to give rest than that after exercise if the patient is complaining of the severe pain. And the analgesia as per the choice of the surgeon, which help to decrease the pain and it also help to accelerate the rehabilitation. So we begin with the rehabilitation with the passive range of motion, which is followed with the help of a therapist, that is also the passive, and we start the stationary biking once the range of motion has raised 110 degrees. So immediately after the reconstruction, there is always a fear of the weight bearing in a operated limbs. The patient neglect the weight bearing in operated limbs. So the from the day one post of this, we train the patient the equal weight bearing on the injured as well as a good leg. We train the weight shifting to lateral weight shifting, forward weight shifting, as well as a backward weight shifting, which helps the therapist as well as the patient for the further rehabilitation process. Heel prop we use to to avoid the extension lag. Also, we can use the pro knee hanging for preventing the extension lag. Once there is a good control of the quadricep, we perform the three-way SLR, that's the flexion, abduction, and adduction. Uh, in, in case of a hamstring graft, we delay the extension exercise, the extension SLR till 3 weeks. Then after that, we can add the extension SLR. So hamstring curl is not allowed till 4 weeks of the rehabilitation phase in order to protect the graft donor side, that's the hamstring. After that, we can add on the hamstring curl. In the early phase of rehabilitation, all the isometric exercise will be replaced by the resisted exercise. The resistance can be given with the help of weight cuff, TheraBand, and the exercise can be done in a sequential clockwise manner. The open chain exercise is started during this phase with within the range of 90 to 60 degree. Uh, Biofeedback is given when we are teaching the exercise to the patient so that the patient comes to know about the alignment of the body, as well as we can see the clear view of the knee position. That is, most of the time when the patient are doing the squatting exercise, the knee goes into the valgus. So the proper alignment of the knee along with the kinetic sense of knee and ankle should be taught to the patient, as well as the proper co-contraction of the hamstring and the quadricep should be there. So the proper activation of the muscle should be taught to the patient, so that the patient can feel the muscle activation while doing the exercise, and avoid the weight bearing on the injured leg. So this will be progressed with the forward lunging and the lateral lunging with the help of the mirror feedback. So progression of the exercise, double leg breathing is progressed to the single leg breathing. Active knee extension, we do not allow to do the active knee extension till the phase of a remodeling and a maturation, because the study have shown that the ACL is loaded more in between 50 to 10 degrees. So we allow the active knee extension only after 3 months. A couple of stretching has been practiced during our rehabilitation: calf stretch, quadricep stretch, hamstring stretch only after 3 weeks of rehabilitation, IT stretch, and the sustained stretch. We perform sustained stretch if the patient is back after 2 to 3 weeks of a rehabilitation. We give the sustained stretch for which will be starting from the 5 minute and progress to 10. So neuromuscular training exercise. So neuromuscular training provides dynamic stability, coordination, improve the movement pattern, as well as it helps to prevent the recurrence of the future injuries. So when we are teaching the neuromuscular training, we'll be beginning with the double leg neuromuscular training and further progress to single leg neuromuscular training. After that, balance helps to improve the proprioception, posture stability, as well as it helps in automaticity of the activities. So dynamic balance also will be progressively increased. Uh, Increasing the difficulty level, can use a balance pad, boso, as well as a balance stakes, which helps to uh, improve the core as well as the stability of the patient. Running will be begin in a phase of a remodeling phase, firstly in a single line, straight line. After that, the progression will be zigzag pattern. So TRX exercise is done in conjunct to the rehabilitation, in which we can perform the vertical jumping as well as a lateral jumping, which will be done in a lateral phase of the remodeling. Core is thought to be the base for the activities of the lower limb. So the proximal, as there is a saying that the proximal stability is must for the distal mobility. We work on a core from the beginning with the simple core exercise to the hardcore exercise. Similarly, and the TRX exercise for the upper torso. Power training. The power training helps for the quick action of the muscle and the force generation within a certain period of a times, which is very important for the players when they are playing the games. So once there is a good strain, proprioception, and the cardiovascular fitness, we begin with a plyometric exercise, which improve the power as well as prevent the further injury when the players go back to the sports. agility drill. Agility drill is good for the acceleration and the deceleration phase of running, and is helps for the good control in it. So before going back to the sports, we always do the hop test in a patient. That is a triple hop test, single hop test, as well as a cross hop test, and it should be more than 90% compared to the good limb. Uh, During the different phase, though the physiotherapy protocol have been remodified from time to time, yet there is no mention about a specific exercise during the different phase. The exercise is added on the basis of physiological and the biomechanical changes that is seen during the rehabilitation process, and the based on the graph graph stage. So the proper knowledge about the physiology and the biomechanics helps to add the different variation of exercise in a different phase. So we have been following this protocol, and yet we haven't seen any complication when we are rehabilitating the patient. And previously, the back to sports has been preferred as early as possible of 6 months. But nowadays, due to the advanced study or the research, it has been changed from more than 9 months due to the Perez MRI and the biopsy study. As Dr. Piper has already mentioned, that the ligamentation and the maturation take place more than 1 year. So the back to sports has delayed to more than 9 months in a nowadays context. Thank you.
Congratulations, Nijan, for your wonderful presentation. It was a really well
Thank you, sir.
illustrated with all the videos. So, is there any queries and questions? We can unmute and ask. Yeah, Amit sir.
First of all, I'd like to congratulate Nizam for this excellent presentation, and also would like to mention that Nizam is, preparing a very comprehensive rehab protocol. But what I personally feel as a surgeon is that we need two groups of rehab protocol: one for a general population, one for the
Sir.
sport person. In general population, 95% of our patients that undergo surgery, these are the general population. So they just are weekend warriors, and many of us are, we operate on, office goer. They have nothing to do actually with the sports. And there are other group of people who really wants to go back to their sports and all, and probably this has to be divided. And when we plan our rehab protocol, we have to, have a in back of our mind. We have to think that not many people can come to you all the time and all the phases to come to you. So there was a very nice study even done by Shelbourne and so many other colleagues, his friends, comparing the home-based physiotherapy after ACL reconstruction with the supervised rehab procedure. So what is your take on Nizam? Can we plan a home-based physiotherapy for patients who are not very high demand patients? These are just office goer or not very high demand. What is your take on that?
Yes, sir. The exercise program is planned as per the demand of the client. If the patient is demanding, then we'll be planning the exercise as per their demand. If the demand of a patient is just, I should be able to walk, I should be able to run, we'll be planning our program as per that. If the patient is of high demand, we need to change our rehabilitation from the beginning so that it helps for the further rehabilitation of the high level exercise. So the home-based program is a good exercise program if the patient is of a low demand, which demand needs of walking and just running. But the home-based program will not be enough if it is for the players who wants to go back to game.
Okay. And Nijan, Vivek here.
Yes, sir.
Nijan, we have been talking about Graft from our last webinar. So during your clinical practice, have you, what is your experience regarding the quadriceps and hamstring control in regards to grafts. So sometimes we take quadriceps graft, BPTB graft, and many times we take the hamstring graft. What is your experience regarding gain of hamstring strength and the change in your do you do any change in physiotherapy protocol according to the graft choice?
Yes, sir. When we are taking the BPTV graph, there is always a good control of a quadricep. But when we are taking the hamstring graph, it is very difficult to regain the strength of the hamstring rather than in case of a BPTV. So
Okay.
we have to work more on a hamstring in the later phase in case of a hamstring graph, along with the quadricep muscles. So this difficulty is found in case of a hamstring graft, but it is less common in case of a BPTV graft. So
Okay, what about quadriceps? Any experience?
in case of a quadricep muscle, also in the initial phase, if the quadricep graft is taken, we have faced difficulty in the initial phase only because of the scar and the donor morbidity. Later phase, it is very easy for the rehabilitation process if we are taking the quadricep, but we have to work hard in the initial phase if we are taking the quadricep grafts.
Is there any time frame that hamstring strength is regained at about 2 months or 3 months or 4 months time after the hamstring as a primary graft?
Basically, we are delaying the hamstring activities, the proper hamstring rehabilitation till the 6th week because of the donor site in case of a hamstring graft. So it will take a longer time of around 4 months to come back to the normal strain of the hamstring. So we have to work on hamstring strengthening once we have passed the 6 weeks of the rehabilitation time, sir.
Okay, okay. And sorry, I have final question. So we are taking two important hamstring, the gracilis. Usually we take two important, semitendinosus and hamstring. Um, do you find that final hamstring power is very different from the contralateral side? And it will be very problematic for the high level sports person. Is there anything like that? The final strength which you can gain with physiotherapy is different from lesser than the normal side. Is this like
When we are rehabilitating the patient after the hamstring graft, we have seen that there is no 100% in compared to the good limb. It is around 95% the strength of the good limb. We are not being able to get 100% exact 100% of strength we cannot get for the hamstring graft after the rehabilitation, sir.
okay?
Only
Okay,
90 to 95% we are getting, not 100%, sir.
okay, thank you, Nijan. That was excellent.
Nijan.
Yes, sir.
Hello. Hello. Very good comprehensive presentation on rehabilitation of the ACL following ACL reconstruction.
Thank you, sir.
As you mentioned about the OKC open kinetic chain and closed kinetic chain exercises.
Yes, sir.
And here, following a reconstruction of intercruciate ligament, knee stability is very, very important.
Yes,
and
sir.
among them, quadricep has got the highest importance because until unless the good quadriceps function is achieved, you cannot mobilize the patient well, and even the weight bearing also that can lead to a lot of rotatory and varus valgus the moment in the knee. Okay, that can have lead to adverse effect on the strength of the reconstructed ACL. What is your take? Like, when do you start? As you mentioned to some extent, but how do you decide whether open kinetic chain exercise to be started or not? Or in recent studies, some also say that in order to achieve the strength of quadriceps muscle, you have to allow the patient to do open kinetic exercise also. In two group of patients, those who are doing open and close has got a better quadriceps control than the closed kinetic chain only, and the ultimate function will also be recovered. What is your opinion on this?
Basically, we perform the closed chain kinematic exercise if there is a good control of the quadricep. Until and unless there is no good control of the quadricep, we do not prefer the closed chain kinematic exercise, as well as because good control helps patient from buckling up the knee, as well as the proper locking will be there if there is a good control of a quadricep, as well as initiation of the closed chain kinematic in case of a patient is very difficult because of the confidence of the patient, fear of the patient, and also we have to be in a safety size in initial phases. So we begin the close-in kinematic only after there is a good control of the quadricep muscle. And initially we begin with the low range close-in kinematic exercise that is between 20 to 30 degree, where there is a co-contraction of the quadricep and the hamstring muscle. Due to this, there is the good protection of the ACL graft. So talking about the open chain kinematic, uh, basically after the rehabilitation, reconstruction of the ACL, the knee will be placed in a brace, the immobilization brace for 2 weeks. And if there's a good control, we'll be removing the brace after 2 weeks. Then after, we'll be starting the closed open chain kinematic exercise without affecting the graph side. The study have already shown that the graph is loaded more in between 50 to 10 degree. So when we plan our exercise, initial exercise program will be done within 90 to 60 degree, so that there is no load on the graph. Also, the study has shown that when the quadricep is contracting at the angle more than the 60 degree, it causes a posterior translation of the tibia, deloading the ACL graft. So we will be planning our exercise program within the range of 90 to 60 degree if you are planning for the open chain kinematics. And when we talk about the results and the study, there is always been a controversy using the open chain and the closed chain exercise, and they have concluded that the proper and the good combination of the open chain and the closed chain exercise should be given to the patient with the better knowledge on the grappling side. So,
Thank you very much.
Okay.
Thank you, Dr.
Nijan.
Amin.
Thank you very
I wanted to ask one question. This is Nagmani here, Dr. Amin.
yes, sir.
Nijan, could you tell me regarding some of the steps in hamstring regarding neuromuscular strength training? What are the exercises and when do you initiate it? And the second thing is cable exercises when we talk of like RIP 60s and all, TRX. What are your goals prior to starting those? And what is whether it's time or whether it's a specific goal which you look for before initiating those?
So basically neuromuscular training will be starting from the beginning. That's after 4 weeks. Basically, neuromuscular control means a better control of the joint. The first neuromuscular control exercise will begin with the balance exercise, single leg balance, and the squatting exercise, where there should be the good control of the knee, preventing the knee going into valgus, as well as a good amount of control of hamstring and the what is a co-contraction. So we will be starting from the beginning, the first phase, without loading on the ACL graph, and it will be progressively. We will be adding the progression in the neuromuscular control. That's a supported squat, from supported to non-supported, and with the increase in the flexion of the trunk, which helps to in the recruitment of the more hamstring muscle. And when we are talking about the TRX muscle, the TRX muscle, in order to start the TRX jumping, and there should be a good control of the quadricep and the co-contraction of the quadricep and hamstring muscle. So before beginning that, we will be teaching the patients to stand exercise with a good control, and the squatting, isometric squat should be done within the range of a 60 to 90 degree. And there should be a good hold so that we can progress to the TRX exercise. Basically, TRX exercise jumping and double leg jumping and single leg jumping will be added in the latter phase. That is a remodeling and a maturation phase. Sir.
Thank you, Nijan.
Okay, thank you very much, Nijan, and thank you very much all the participants. I would like to request, please put on your queries in chat box. Nijan will be replying all those things in chat box. We're having shortening of time, and without delaying, I would like to move on further. I would like to request to Dr. Sailas Ranjitkar sir to present the real life surgery, that is how do I harvest hamstring graft. Sailas sir.
Something's wrong. Sorry.
Sir, please unshare once and share again.
Is it?
Okay.
Okay. Can you hear me? Hear me?
Yes, sir. We can.
Yes, sir. Yes, sir.
Can you hear? Okay.
Yes, yes, sir. We can see as well.
Yeah. Good morning, everyone. Well, I'll be talking about hamstring graft. Thanks to everyone. Lovely presentation by Vivek, and from the physio point of view too, and makes things very clear. Well, about hamstring harvest, the topics I'm going to, briefly going to tell you about shortly about the anatomy, the advantages, disadvantages, a bit of a controversy about lizard tail phenomenon, and how do you make a skin incision, how do you open up the sartorial fascia, are you going to use an open or closed stripper? These are the few questions that will go on your mind when you initially start off doing it. Do you need to close the sartorial fascia? What technique should you use to stitch the ends of the graft? All these things will go on to the technical video part. What is the required thickness of a graft? These are the few things that will be in your mind before you start off considering graft. The technical video, I must thank my colleague, my friend, Rajiv, who's kindly given me this video, and which I will be sharing with you all. So let's start off with anatomy. We've talked about the hamstrings that we remove, the semity and the gracilis. So the patient will ask you, doc, if you take the semity, my hamstring out, will it cause a lot of problem to me? Say if it's a normal person. So I think it's important to tell them that there are other hamstrings like the biceps femoris, the semimembranosus, and gracilis though it functions like a hamstring, it is actually an adductor muscle. And one also needs to remember that the ischial fibers of the adductor magnus is also functioning like a hamstring. So anything that comes from the ischium goes down below the knee, which causes extension of your hip and flexion of your knee, is part of the function of a hamstring. And that's what is necessary for sprinters. So that's when you want to try and avoid taking the hamstring. So I think this part of the anatomy, to get a concept that there are other hamstrings and how it's going to affect the patient, it's important. The lower part is just a picture there. You can see the sartorius. Your gracilis and semity lie on the undersurface of the sartorial fascia. And the most important thing below it, which you don't want to go really cutting, is the MCL, which lies below it, the glistening white structure. So when we go on to try and harvest, this is the few anatomical things we need to be aware. Advantages, you can see from this literature, there's a huge list. Easy to harvest, decreases anterior knee pain. You can increase or decrease the sectional area. Cosmetically, hamstring is much better. There's lower donor morbidity, comparable strength to ACL. We know that the ACL has about 200 to 2,500 newtons of strength, PCL being 2,500 to 3,000. So when you have a quadruple graft, you have a similar type of a strength or even more. If someone has got a chondropathy, then you can consider using this. People who are kneelers, like wrestlers or who are jumpers, you want to avoid using BTP. And advantage of this that you can pass the graft very easily compared to the PTP. Less chances of cyclops lesions. And you can individualize the length and the diameter. You can play with the diameter and length depending on whether you want to quadruple it or whatever you want to do with it. So there's a gross advantage of it's very easy. You can take it in different directions. So there are other papers also saying similar things. It's just that if the advantage of a hamstring over the PTP is that the last 5 degrees of extension is less in the hamstrings. And in the long run, if you look at it, the clinical and functional outcome compared to PTP or quadriceps tendon or hamstring, it's all comparable. So why not use something that is easy? And so that's why I think hamstring is preferred by many compared to others, though others are also coming up in the scenery, but the hamstring is very advantageous. Disadvantages, just part of it, we can see there's a long ligamentization problem, which Vivek has already mentioned, a bit of infection, hematoma. The graft size is unpredictable. Our Nepalese population, we have difficulty getting beyond 7 millimeters. And it is a more complex preparation. Graft laxity is a bit more. There's a bit of tunnel widening. Yes, saphenous nerve injury is there. But saphenous nerve injury is in anything, whether you do bone tip patellar tendon. Of course, in the quadriceps is not much of a problem at BTP, or even if you do a total knee, you have any incision down the middle of your knee below the patella will cause a saphenous nerve injury. And it's how you try and avoid it, that is the important thing. It's one thing about it is that they can have residual muscle tear. So because only the biceps and the semimembranosus are the big bulky muscles which are holding on once the semi-T has been removed. So in aggressive athletes or sprinters, we have to be careful about that. That's probably the controversial thing about it. Similarly, there are other papers considering laxity more to PTP, and one paper has shown that maybe quadriceps tendon has a better outcome than hamstrings. So there's a controversy everywhere. In general, hamstring is a fantastic graft, and it can be used even in the upper limb, I would say. The gracilis going up and constructing the lateral ligaments of the elbow. So it's a fantastic graft which can be used in different parts of the body. Controversy, now the patient is going to ask you, will it grow back? And there are a few papers here. One is on rabbits, which has shown that 23% of the tendon actually grow back in 16 weeks, the strength, biomechanical strength, and 62% in about 28 weeks. There's also an MR study which has shown that there's an ill-defined function, or the formation of a semi-T by 6 weeks, and by 3 months there is a good normal signal. But the semi-T actually lizardate phenomenon is much better in semi-T than in the gracilis. Now, what incision are we going to make? The different types of incision. Now you can see that you have infrapatellar branch of the saphenous nerve, which can be injured, and lot of the time nothing actually happens. But I've known my consultant being actually sued for a neuroma pain. It can be disastrous when the pain comes in. So yes, we need to try and avoid it as much as possible. Though even if you make an incision down the middle of it in 2 years' time, the amount of numbness on the lateral aspect of your knee is about the size of a 50-paise coin, or about the size of my thumb. That is the usual thing. But yes, if people have problem, they really have problems. So we need to consider the different types of incisions that we have. We must consider where the oblique incision is the best. The injury level is 27.6. So that's the reason why oblique incisions are preferable. And the thickness, we all know that our Nepalese, we have 7 millimeter thickness, but there's the revision rate is 13.6. So we need to get 8 millimeter and above. So these are the few information we need to have before we consider the surgery. I'd like to thank Rajiv for this again. I've edited the sound out, and you can see he's already made an oblique incision there, and it's a small one just below the tibial tuberosity. Now you can try and see what he's trying to do. You can see the shiny fibers below, that is the sartorial fascia. And a lot of the time you get a lot of fat in that area. It tends to bleed. So don't forget to do a bit of hemostasis than making a hematoma there. So that's what he is doing. This is going to be a 9-minute video. So just be patient and gradual see how he gets the grafts out. Very beautifully done. Now he is putting his finger there just to feel the tendons, which will click under the finger. You need to make a bit of a pocket under the skin to make to work a bit easier. Small little incision. And there he feels it. He's going to take an Alice. Well, some people don't use that, just make an incision, but I think this is a safe way. It's like in the abdomen, you're picking up the peritoneum that you don't hit the intestines below. So you pick that up and you make a small incision over the sartorial fascia, and that avoids you hitting the MCL below that. You don't want to injure the MCL, and you go distally and proximally. Here he uses a open stripper, so naturally he's going to open up the whole sartorial fascia and go straight and then longitudinally, so that he can evert that and look at the semitendinosus and gracilis on the undersurface of the sartorial fascia. So that's beautifully done. He's trying to get a good length to try and evert it. He holds on to the edge of the sartorial fascia. Trying to make a bit of a length. Sometimes it is, when you use the scissors distally, it's always fine to try and push your scissors, and that decreases the chance of you accidentally cutting a tendon there with the sharp part of the scissors. Waiting for complete eversion. And below that, you can see the glistening stuff. More towards the proximal retractor, that will be the MCL out there. He's taking a 90-degree forceps, that's a 90-degree cholecystectomy forceps, and that's the semi-T there. He's going to separate the distal attachment from the undersurface of the sartorius. There it goes. That's what he's taking off the undersurface of the sartorius. And that's the distal end of the sartorius. Holds on to that. Release a bit of the tissue. Just be careful that there will be some, you will have vinculars there. Vinculars are nothing but mesotendons. They're the blood supply to a tendon. So we know that there are two types of blood supplies, that is with the mesotendon and by the parotendons. So all these tendons are, so that's what the vincular does. And that needs to be knotted. So he's going to use a tag knot. He's going to double tag it. Some people would just go and do, so the type of, because later on we have to do, what's it called? Whip stitches. Yeah, so he's used a tag knot out there, and now he's going to dissect down to get the vincula away. To differentiate from a vincula from a tendon, Well, the tendon is thicker. Sometimes we have very thick vinculas. So if the vinculas are moving in the other direction, yeah, it's, remember the semity is going towards the ischial tuberosity. So that's the direction. So anything that's going more in an oblique fashion below, the one of the common ones is to the gastroc vincula coming around from the gastroc area. So as you can see, he's pulled it across, the tendon is going across the midline. When you see that the tendon you're able to pull across the tibial tuberosity, the midline of the knee, you know that you've released nearly everything of the vincula. Otherwise, the tendon usually doesn't come out so easily. Now he's going to use a stripper. He's using a closed stripper there. The advantage, disadvantage of both. Open strippers you can use even without actually getting the proximal out, the distal part out. So here in a swiveling, in a rotatory manner, a tight hold on the left hand and the graft is out. A lovely graft. You can see a lot of muscle fibers which will need to be removed later. He's going to go back for the gracilis now. There's a thin gracilis, which functions like a hamstring, but it's, it is more of an adductor muscle, causes hip flexion, external rotation, and flexion of the knee. In similar fashion, he's going to take that off the undersurface of the sartorius fascia, make a similar knot. Usually, finger dissection is quite good enough for the gracilis. You usually get very flimsy vinculars in this, and but it's always good to check properly. Put your finger, if your whole length, you've got a long finger like mine or like Rajiv's, that could go way up. But when you're using the stripper on this, you have to be, you have to consider that the direction is slightly towards the ischiopubic area. So the direction here is different. So there it goes, another stripper. You can see the white MCL underneath. We know that we've not injured it. Again, a wiggling movement, rotatory movement. Keep a left hand a proper tension. Don't need to pull hard, but it's mainly the right hand, and there it goes. And the question is, do we need to bring the sartorial fascia back and stitch it? He's showing it to you. It's a nice, lovely flap. So, and that will need to be brought up high up there and sutured, and that will give you that once you've done your tunnels and at the end, that maybe it would be a good idea to suture that back, and that becomes more anatomical. Thank you. That is the end of, sorry. So I've just put in, that's all about the graft harvesting, I would say. I thought I'd put up this picture to show you the open strippers, to be aware of it. So we have an opening on the side where you can slide it into the tendon and use the stripper. In that technique, you don't have to actually evert the whole sartorial fascia, and even before you release it from the undersurface, you can use the stripper to actually remove or harvest the graft. So harvesting the graft, you can see that on the left, I put up the picture where you have to take all of the muscle fibers out. And there are different types of ways in quadruple it, or to make it 5 times. So whichever way it's been made, Vivek has talked about ligamentization. So the important thing here is, do we need to precondition or pretension it? it's very controversial. I'm showing you two papers here. The first paper, what they do is they don't tension it. They just put it on to proximally distally tighten the thing and put a screw on. So that is a single 80 Newton. Yeah. And the second group is you put them on the board that where you prepare the graft for 20 minutes. Third group, you cycle for 20 minutes. And the fourth group, you do all of them. So what it was shown in this study was that at the end, the creep was minimum in the last group where you did everything. So, principle of viscoelasticity, I think it is a reasonable thing to say that we need to try and avoid creep. So preconditioning, pre-tensioning is a reasonable thing to do. How many cycles to do, whether it's, there's no difference between 30 and 40. So the recommendation was like maybe 30. But on the controversial side, there's a review article, 5 studies, 4 biomechanical and 1 histological, which showed no consensus. Really, does it make a difference whether you do that or not? So, but at the end, I think we need to be careful, and for us as starters, we need to do all stepwise and only graft removal but preparation. But the later part of it, I think Ishwardai will be talking more about it too. So I would end here. Thank you so much. And thank you for listening. Thank you very much.
Thank you. Thank you very much, Sailash sir, for the very illustrative, very nicely presented video presentation. Now I'll just take a few questions from the audience. And there is a question in chat box, sir, from Sanjeev Jal, asking about any tips to avoid any premature graft amputation, sir.
I think it's first of all important to start from the basics, that you do your dissection well. If you're starting off, don't try and make a very small incision. Look in properly. Look for the vinculars properly. Yeah, that is one of the main reasons of early amputation in that area. And I think open stripper is a reasonable thing to use in the early stage, because that I feel is a bit more safer. Put your finger right inside and feel properly. If your tendon, as I mentioned in the video, if you can take it across the center, you know that you've released enough. And your left hand, when you hold on, or if you are a left-handed person, is the other way. But if you are a right-handed person, then you're holding the tendon in your left hand, and that needs to be sturdy. It's not going a very huge traction. You have to maintain the tension in that. And with the right hand, it is a slow, wiggly, circular process, wiggly process, and directing it towards whether it's ischial tuberosity or to the pubic area. But if you find a lot of resistance, check, stop, go back and check again. So don't hesitate to give yourself a bit more time. I think that's how you need to consider trying being safe for early amputation.
Thank you very much, sir. I would like to request all the participants, if you have got any queries, please put your queries in chat.
Amin.
We're having.
Hello. Amin.
Sir. Arjun, sir.
Okay.
Please.
Okay. Can I add something on this question?
Sir, we can have a chat later on in the session, sir. We are having very lacking of time, so I would like to.
Okay.
Go ahead, sir. I would like to request our president of Arthroscopic Society of Nepal, Dr. Ishwar Pradhan, sir, to share his screen and start his presentation, sir.
So am I audible? Yeah.
Sir. Yes, sir.
So, okay, my presentation is visible now?
Yes, sir. Yes,
Okay,
sir,
thank
please.
you. Thank you, Amin. I'm just going to follow up on what Saila's presented. So I'm going to talk about something about management of the graft that is harvested, the hamstring graft, which was very nicely presented by Sailas. So after you take out the graft, he has also shown that you take out the muscle part and prepare it in the preparation board. But even before that, you have to have an idea of what you are going to do. So uh, the graft that has been taken out needs to be managed according to what size of graft you happen. The objective of managing your graft that you have harvested is to achieve a appropriate size graft that will fit into your bony tunnel. So actually the tunnel is the one that actually dictates what size, whatever graft you have harvested can be managed to fit into your bony tunnel. So if you go back to the normal anatomy and what is the standard graft requirement, your graft should fit into the femoral tunnel, the intra-articular part that Vivek nicely talked, which undergoes ligamentization, and the tibial tunnel. So there are three parts which your graft which you have harvested must fit into appropriately. And so just to give you an idea, when you look at the graft, you have a leeway, you have a flexibility in each of these part. So the intra-articular part, from our anatomy knowledge, we understand it ranges from something like 2.5 to 3 millimeter. And you all understand that the anatomy varies from person to person. Somebody might have something like more than 3 centimeter, 33 millimeter, or somebody who's a short person may still have just 25 millimeter. The tunnel you make in the femur and in the tibia is also adjustable, according to the size of the graft which you can harvest. You can adjust the tunnel size in the femur as well as in the tibia, so that you can fit your graft which you have harvested according to this tunnel you are made. So just to completeness, to show to you, that we all understand that we, by textbook standard, want at least 1.5 centimeter of your graft to stay inside the femoral tunnel, and the intra-articular part is something like 2 to 3 centimeter, and the tibial tunnel is usually 3 to 4 centimeter, which can, to your choice, you can adjust. So it's something like 8 to 9 centimeter. The variability comes with your expertise, with your experience. You might have noticed previously we used to say that 9 centimeter may be the standard, but there is a little bit of adjustability which you can do. But the diameter, this is a scientifically proven. There are a lot of reports that which needs to be ideal, and which I think Silas talked about a little about those also, and I'll also show you the same report that are there in the literature. So the configuration of the hamstring graft after you have harvested can be a triplicated or a 3-strand graft. It could be a quadrupled, 4-strand graft. And there are, nowadays that people are thinking that the 5-strand graft, which is the pentable graft, is the ideal one. And then there are people, who describe about a hexaplate. So this is the normal graft configuration we talk about, triplicate, quadruple, pentaple, and hexaple, which I'm going to show you in the live surgery. But just few days back, I was looking around, and then there is this report from LaPrade, which was there just 2-3 years back. This was published in 2017 in the Arthroscopy Journal by LaPrade and his group. And then in this article, they talk about not just triplicate, quadruple, but they talk about the 8-strand graft also. So these expert people, their experience, they have this experience to say that you can even make a 8-strand graft with the both the hamstring, the harvested semitendinosus as well as the gracilis. So if you have time, you can look up this article here. But what I found out there in this article was, of course, their diameter was as the standard diameter 8 to 8.5 millimeter, but there was a little bit of confusion upon what length they actually approved. So but even then you can look up that article. So the choice of graft configuration, as I was talking again, like it depends upon a lot of things, but which are practical is the diameter of the graft. The diameter is the standard one we want. Like also this report, report was presented by Sailas, but Conti, his report was by Magnuson, but Conti did a systemic meta-analysis of all those reports, starting from Magnuson, who was the first person to talk about the diameter graft. But his systemic meta-analysis showed that as also Sailas showed, that if you have a graft less than 7 millimeter, there are 13% chances that that your procedure is going to fail and you will need a revision ACL. If it is less than 8 millimeter, the diameter of the graft, there are 6% chance. But if it is above 8 millimeter, it is only 1.3. And they also concluded that above 8.5 millimeter, it's just 0%. They have gone up to 9, but beyond 10 millimeter, they do not say anything about whether it's going to be the perfect one. They still think that needs to be further studied. But what they say is 8 to 8.5 millimeter diameter graft of the hamstring is the ideal one. What they also showed was when you are increasing the diameter of the graft from 7 to 10 millimeters, the revision rate is decreased by 0.86% in every 0.5 millimeter increase in the size of the graft. The other thing you have to consider is the length, that I showed in my previous slide. The tunnel you can adjust, and accordingly the graft length can be adjusted. And the patient profile has to be taken into consideration. The anatomy from one person to another varies. The sex of the patient, because we all know that not only sex, the race, our kind of people are short people. They not only have short graft which we can harvest, even their knee are so short, making a tunnel with a 10 size endoscopic reamer in the femur is very difficult. We all know that the height, the taller the person, you can have a better graft harvest. And of course, what size you want to use also depends upon the occupation. The person who is an athletic professional will need a graft which is at least 9 or 10 to get him back to his sport, and to get a better press fit and better healing. Type of fixation also helps you to adjust your length. You can vary your length of the endobutton loop so that the tunnel placement of your graft in the femur can be adjusted. And in the same way, you can use interference screw as well as post if you do not have. The other thing is your expertise. You start with doing just 4 quadruple strand or a 4-strand graft, which is the easiest to make. Then you promote yourself to using a triplicate, and then a pentapole, and maybe into a 8-fold what the lab-rat people have described. So this is just a presentation and a pictorial presentation. If you are successful to harvest a semity which ranges from above 24 centimeter and even up to 27 centimeter, you are very likely to get a 3-strand which is 8 to 9 centimeter, and they usually have a 8 millimeter. This is the presentation. This is from Charlie Brown's article. It was just about 2 or 3 years back. It was an editorial commentary by Charlie Brown, who used to work in Boston, in America, but he shifted to Abu Dhabi, and he was saying that in Boston, he was practicing with the 4-strand quadruple graft, but when he shifted to Abu Dhabi, which is like the Asian continent, where people are short, you have you can harvest a graft which is as big as the race or the patient can afford. So there he started using 5-strand graft, which approximated to his demand of 8 to 8.5 centimeter. This is a book just from Noise, which I've taken out from Noise. This is a little bit old, they just show a diagrammatic presentation, and this is a triple strand configuration of the hamstring. So this is just a short video I'm going to present here. Why is it done?
सर त्यो भिडियोको सोर्समै गएर देखाउनु सर, यो प्रेजेन्टेसनमा केही प्रब्लम भयो कि?
लेजर अफ गर्नु सर, लेजरले गर्दा पनि हुन्छ सर।
लेजर अफ।
Okay, yeah, I think so. Thank you. So
Yes,
this
yes,
is how, you know,
you're right.
we have that hamstring nicely whip stitched at both ends, and you can see that there is a folding you can make. What you have to do is you have to engulf the end, you know, put the end of the graft into the fold. And as I've shown, you know, in the folded part, you can pass your endo button, then you have a very good size, you know, 8 or at least 9 side of triplicated hams. So this is a quadruple. This is the easiest one to prepare. You know, you should have an adequate length of gracilis as well as semity, you know, even less than 24 centimeter, because your aim is to get something like 8 centimeter or 9 centimeter. So if you have a semity which is less than 24 centimeter, you have to harvest the gracilis also. And gracilis graft are usually not that, you know, longer than 21, 22 centimeters. So you just fold both the gracilis as well as the semity, and you have a quadruple 4-strand graft. And you have adequate length, you know, and you have something like 10, 12 centimeter. And when you put your graft inside, you can still see a sizable amount of the tail of the graft coming out of your tunnel. And they usually land up with the 8 millimeter diameter of the graft. And you can see here, you just fold both the strand of the hem of the gracilis as well as the semitendinosus into the loop of the endo button, and the other end is just free, and you can just pass it up into your tunnel and, you know, fix this tail end with your interference screw. Quadruple hamstring, yeah, just a presentation. It's just nothing, you know. You just put the 2 strands together alongside, you know, and then put a suture to fold it, and then just measure it. You know, it's an adequate size of 8 to 8.5 millimeter. So this is the one, the triplicate one. You know, you have 2 advantages here. If you get a semity which is 27 centimeter in length, you know, and you can triplicate it into 8 or 9 centimeter. And you usually, you know, in most of the triplicated cases, you get a 8 millimeter size. But if you have less than 8 millimeter and your patient profile is such that you want to put a stronger one, maybe the patient is a athlete or a highly, you know, athletic professional, or highly outgoing, or a male in their young age, you know, so you want to add your diameter size, so you can just add your gracilis also, you know. You just, like, for example, here you have your semitendinous here, you triplicate it, you have that triplicated semity, and on top of that you just pass your gracilis through the loop, and it becomes a 5-strand, and this definitely would give you a better diameter, you know, at least 8.5 or 9, even 9 size of the diameter of the graft. So live video presentation here, you know, you have already made the triplicated semity, and on top of that here he is passing the gracilis just to fold it, you know, so it becomes a 5-strand graft, which is also called a pentaple hamstring, and this usually gives you a 8.5 or 9 millimeter graft. Lastly, the six strand or the hexapod, you know, this you can, I think you can make only if you are lucky enough, you know. Gracilis, as I said before, you rarely get gracilis which is more than 27 centimeter, you know, it's usually 20, 21 centimeter. And if you get a semity and gracilis which are both more than 27 centimeter, you can triplicate it into either a 8 or 9 millimeter length. It's just nothing, you know, like you put it there side by side, you know, you fold it like what you do for a single triplicate one. And the amazing thing are, you know, people who have more expertise, you know, they can even taking this triplicate, both the gracilis and semity. If it is even less than 27, you get a total length of 75 millimeter. That's 7.5 centimeter, much lesser than what we are. Like I said, this depends upon your expertise, you know, your experience in, and what type of ACL reconstruction you will do, which I will talk later on. So this is just a picture from Charlie Brown's presentation. These were also presented by some of my colleagues before. 6-strand ACL, a hexapod. So this is just a live video. We have just put it there. Both the gracilis and the semity, and we are triplicating both the ends here. It's a little bit tricky with the sutures there. So you have to be clear where you are putting everything, so that both the sutured end goes under the loop, and you can tie the endo button with its loop firmly there. So you can see with this hamstring, with this 6-fold or a hexapod hamstring, you get quite a big, 8.59 diameter graft. So when you really do land up with, like graft, which is short, but it's not just managing the graft, you can manage the other aspect, For example, you can manage the tunnel length with the direction of the jig. So you can adjust the length of your tunnel and the length of the graft you prepared, you manage from the harvested. You can, as I said before, you can use a longer loop, endo button. There are now, newer techniques coming on, which is called the all inside technique. And, in this kind of technique, you can use even a 6 centimeter, people are showing that even they can use 5 centimeter with just, less than a centimeter, about 1.2 centimeter within the tunnel in the femur as well as tibia, because there are people like Amit was saying, Bansa, who believe that it's not the intra bony part that is dependent, because practically it is so also. It is the aperture that is necessary, and the press fit, how tight, how thick the tendon, the graft is, so that you have a press fit in the tunnel. And it doesn't matter how deep you go into the bone. But the standard teaching for the beginners is that at least aim to put 1.5 centimeter of your graft into the femoral tunnel. And as you become, experienced and you have more confidence and you follow up with your patient, then you can, say that you can manage with a 7 or 6 centimeter graft. And the other alternate, which is actually, I put it here, use of peroneus longus tendon and the CQT tendon, and in especially very, short female patient like ours in the Asian continent, who have a very poor, production, poor hamstring, which are short. But this does not lie true for the Western country, because in the States and in the Western country, these ladies who have more chances of having an ACL injury are the athletic ladies. They are tall, they have good muscle, and they usually do not have that problem. So our group of patients, in our continent, we might seriously need to think about using PLT or a CQT, PLT, peroneus longus tendon, or a central quad tendon for our group of younger ladies with short statures who will yield short autografts. So just to show you that, like if you modify the entry of your jig, if you put it more medially, you can shorten the femoral tunnel. In the same way, your aim of making a femoral tunnel, your tunnel can be adjusted. And in the same way, like at the sagittal section, like if you decrease the angle of your jig, you can, maybe the standard people say is 55 to 66 degree, but if you make it something like 45 degree, which is a bit shorter, you can have a tunnel somewhere around here, which can, give you a tunnel which is shorter, and you can put a shorter graft inside. Similarly, I'm just showing that with the use of the endo loop, you have a place to play around, flexibility to adjust your intra tunnel part of the tendon with the loop. These loops come from varying sizes, starting from 10, 15, 20, 25. So if you can adjust this tendon, this loop size, you can adjust the amount of graft that goes into the femoral tunnel, and hopefully you can use a shorter graft, if you get a yield of graft that is short. So this is the technique I was talking. This is the all inside technique. They have a special flip cutters, like here you can see, where is this? There is a flip cutter. I was planning to show it here, where you can drill from inside, and the measure and the amount of tunnel you make from making the femur from inside, you can adjust. These are the flip cutter. And also in the tibial side, you can adjust the socket or the tunnel that you make to put your graft from the inside. So you can use, for example, in this picture, you can see that you have this all inside technique where you have the limited, socket you have made, and you put your graft, even shorter graft like 6 centimeter, and you can, tightly snug with a endo button on both sides, So this part is there, 2.5, something like that. And this may just be at least, maybe even lesser than 1.5. So something like 2.5 plus 1 is 3, and another 1.5, something like 5 to 6 centimeter. So these are the newer things that are coming, it's just that I wanted to share with you my technique of how I used to do my hamstring, harvest. So I think just a 5 minutes. So I'm allowed to, like take over as the president for a 5-minute overtime, So, oh my God, it went back. Okay. So I usually did my, hamstring harvesting with the knee flexed and standing on the same side of the patient and feeling the graft. Feeling is the very most important thing for you to identify the incision. I always use an oblique incision, and most interesting finding is you usually see there is a blood vessel there. You see there is a lesion vessel there which you need to coagulate. Otherwise, your field will be totally obliterated. So I do the subcutaneous dissection. Make sure the vessels are cauterized. I put my oldest instrument, the finger, to release all the soft tissue. Otherwise you can use a clamp with your gauze and release the soft tissue. And I come to the other side, and as Rajiv did, you must get a good hold of your tendon and lift it up, so that you don't, when you lift it up very nicely, you get a empty potential space which you can just puncture, and there is a sound, a popping sound. So that way you cannot damage the deeper middle collateral ligament. And then you pass your scissor, just at the superior border of your incision. When you come to the tibial side, you make a vertical incision, just, just along the tibial scene, but there will be a little bit of bleeding because there will be blood vessels there. And then you can just, you can reflect the superficial, the sartorius fossa from inside, without damaging the medial collateral. And what I usually do is I try to hook the semity as well as the gracilis from the inside of the inside here, yeah, this is the, and I usually try to lock both of the gracilis as well as the semitendinosus, because if you just lock the semitendinous and take it out, you will lose the gracilis. So it's better to find out both the tendons. The semitendinous is more deeper. You lock the semitendinous after you lock the gracilis, but do try to separate and lock it with your locking sutures so that you don't lose it. So losing tendon is a big problem in hamstring. I wanted to ask a question to Sailas also. What happens if you accidentally lose? It's a big problem. I've faced it many times. So after you have really identified your semitendinosus, I make sure, like I always, I just don't leave it there with the hooked suture. I always, whip stitch it, because there is every chance that it can go back and retract, and when it retracts, that's a big problem to find it out. So I always make a whip stitch or a finger trap suture, and then as already shown by Sailas, you make sure that it is loose. You take out all the vinculas, put your finger and make sure that it has come out of your the tunnel and goes over the anterior tibial scene, and then finally you put your stripper and take it out. And it's very important that you repair your sartorius fossa, back. So with that, I think I will stop here. Thank you. Let's have some more discussion. Thank you for your attentive listening.
Thank you, sir. So we have already crossed the time, and so we are shortage of the time. So I will request only some discussion we can go forward, sir. Our last session was about the tip and tricks, sir. So can we have some time for tips and tricks?
Yeah, I was saying, when you're harvesting a hamstring, losing the tendon into the tunnel is a big problem. Sometimes it makes you, panic. So there are Sarah, there are a lot of tips to, get away with that. One thing is you make sure that you release all the vinculas, that goes from the fascia in the calf up to the semitendinosus. Make sure, they say there are something like 5 or 6 vinculas there, which you make sure you release, and make sure that the tendon comes out of the tunnel and it crosses the anterior seam of the tibia, and it will make sure that you have no vinculas attaching there, and you can release that. Even if you sometimes accidentally lose the tendon into the tunnel, there are techniques, people say that you don't panic, you put your arthroscope scope into the tunnel and find out the detached, the end of the semitendinous that is retracted back, and you can pull it out. The other technique people say is that if you can't find out the lost hamstring, you make an incision in the posterior medial side, in the outside of the thigh. You can feel that tendon there and take it out from there. These are little bit tips and tricks, you can go along and face to if you really lose the hamstring, in your process. Premature amputation, I would say, So are there any questions besides that?
Dr. Ishwar, I want to ask one question.
Yes, sir.
Particularly when you multiply the graft sizes, to quadrupler, 2 pentaplex, or more than that, and when you load the loop,
yes,
usually I find there is a difficulty in mismatching, because the sum of part of the loop gets incorporated into the thickness of the graft. And many times I have faced the flipping of the graft. I find it difficult. So many times I had to take it out and then increase the length of the tunnel and then put it. So can you give some tips that many times when you are increasing the number of graft strands, some part of the loops are incorporated in the graft thickness, so the actual length of the graft reduces, and your calculation doesn't work in that.
Yeah, I totally understand. I quite agree. It's not just the length, even the diameter increases sometime,
Yeah.
And you think that you are reaming with just 8 millimeter, and with the knot tied to the graft, it becomes 9. So it's a practical thing that we also face, What we actually do is that we maybe go a little bit oversized, if you get a 8.5 or a 8 just over drill up to of half a millimeter, 0.5 millimeter oversizing the tunnel is one thing. And make sure that your sizing, when you measure your graft that is prepared in the table, that you do a proper sizing, you measure your diameter properly with your sizes that come with this set. And when you suture the endoloop into the in the foldings, it's better to put that in the folded end, and within the loop, I can explain only, I don't have that pictures. You can tie the reflected end of the grafts into the loop, one side of the loop, the other side of the loop, so that it becomes stationary. The other thing I could show you here was can I share the screen now here?
Yes, sir. Yes, please.
So the picture I showed you, done by Charlie Brown, like I found it very interesting. This could be one of the what it does here is, you see, like he has already tied his endoloop to one end here. Can you see that? Okay. Sure. So at the other end, he has tied a tape. See, this is a tape. This is not the whip suture, whip suture. So now he has shown that how to fold the semitendinosus, into three strand. Maybe this can maintain, since you have two ends tied to already what you want to, tag it with. You have the endo button at one end, and then at the other end you have the tape. So this might get away, but we don't use this technique. We first fold the triceps and then suture this loop, not at this end only, but also at this loop, the folded part. I mean, this might help us, by making sure that the triple strand length is equal. Okay, but there are many ways, like I said, there was this recent report from Laprat about 2-3 years back. He's talking about making the graft 8 strands. I don't know how they do that, you know. They were talking about just one semitendinous, making it into fourfold. Probably they will compensate in the length, you know, because they feel confident that something like 6 or 7 centimeter of graft may be adequate for their tunnel, intra-articular, you know, femoral and tibial tunnel. That kind of thing is there, you know. It's I think it's still evolving. Yes. Any questions from anybody on any subject that was presented? You know, Vivek had a fantastic presentation. I just wanted to point out, you know, like noise. I also read noise book. You know, I was always of the idea that when you do a BPTB graft, you know, it was more of a bone-to-bone union. But what he has clearly stated is that I wanted to ask in the last presentation also to Arjun, you know, who does most of the, I think he's more experienced in doing BPT. I don't do BPTB because the tendinous part from the patellar end to the tibial tubercle is something like 4.48 millimeter, even sometimes 5, you know, sometimes it goes up to 6 centimeter, you know. So the intra-articular part is just around 2.53 centimeters. So when you put your BPTB, there is still a portion, some part of the tendon, which is inside the bone. It's not just a bone-to-bone healing. So Noyes had pointed out that even in a bone BPTB graft with the tunnel, you know, there is always a tendon to bone healing. And of course, he also pointed out that, but when you have the bone plug into the tunnel, and as Vivek rightly pointed out, you know, you put your screw and there is this osteonecrosis of the bone. But since in the bone you are putting your interference screw, there is evidence that the callus formation, it's like a compact, you know, rigid fixation. The callus formation around the bone, maybe not into the whole of the tunnel, starts by 3 to 4 weeks. So osteonecrosis, it's like a union healing a fracture with a primary compression where you know, compress the end of the bone. So even with the BPTB, the tunnel part, some part is occupied by the tendon and some part where there is only bone, there is healing, you know, of bone-to-bone healing, which Noyes says that occurs by 3 to 4 weeks. So we are in the right path, you know, to do early mobilization there. So anything from our, you know, from our participant, from our presenter, from our senior, Dr. Sudeep, Sailas, Rajiv, and if there are none, we are 15.
I think it was a very wonderful discussion.
Thank you, sir.
Thank you, everyone. Thank you, everyone.
Arjun sir wanted to add something.
Yes.
Arjun sir.
Yeah, it was that question about that premature amputations. I'd like to give some tips. Because first of all, you should identify the tendons, hamstring tendons, and then isolate them safely. Because if you put a right angle, this forceps or any hook to isolate it, it can cause tethering or of the tendon if you put toward the distal part. Distally, it will be this gracilis and this semitendinous tendon will be merged. So you got to go more toward the proximal side. And another part is already Sailas mentioned about the vinculas, they need to be removed. And third part is you should insert your finger quite proximally, and so that you will feel some constriction over there. It's like a pulley effect that is by the semi-membranosus tendons expansion. And sometime if you insert your stipple, then that also blocks. If you could not make the exact direction to go through that constricted part, then this is also one of the side for the premature amputation. And another is like Sailas also mentioned about gracilis attachment direction is toward the pubic tubercle, and the semitendinosus is toward the what is called ischial tuberosity. So that during
passing and giving strength, and stripping also, we should be careful about the direction, so that helps to prevent the premature amputation of the tendons. And then regarding Dr. Ishwar's presentation, as you said, like in all inside technique with the flip cutter trimmer, you can make a small tunnel from inside on the tibial side also. So it becomes, in that situation, you can put a smaller length graft also. But even in through and through tendon, if you fix it with the intertunnel with the interference screw, and you can add a secondary fixation device. It's like a post end. So in that situation also, you can use, if you could not manage the exact required length of the graft, you can do with the 7 centimeter also. In many times I have done that way also.
Yeah, yes, I totally agree.
Yeah. I had one last question to Dr. Shailaj. Dr. Shailaj, are you there?
Hi, yeah.
With the oblique incision, to what extent have you been able to avoid the damage to the infrapatellar branch of saphenous nerve? Theoretically, yes, but to what extent have you been able to avoid?
Frankly speaking, I don't use an oblique. I go for a longitudinal one, and that's what I've always been using. I haven't had a huge problem. They always complain of numbness on the other side. My obliques, I think Rajiv does that, and I think Ishwar Dai also does. He's probably lifting.
Do you ever look for the branches?
No. You can never look for it. Like if you do a total knee, you putting an incision right down the middle.
I know.
Yeah,
I know.
and you're doing a PTP right down the middle. And at least in total knees, what I've seen in patients is, I always tell them that there will be numbness throughout your life the size of your thumb on the lateral side of your knee. Okay, so that's usually a nice little coin area on patellar tendon collateral. So that's always there. How much you can really avoid it is a big question, but theoretically, that's what is the evidence.
I think Vivek can tell that. I think Vivek, you have presentation paper also on paper there.
I just want to say that
so let me intervene on this. We have published a paper in 2016 in an index journal, and then in that one it was a randomized controlled trial. We have compared infrapatellar branch of saphenous nerve injury in vertical and oblique incision, and this is not our only our study. There are a lot of study which is saying that the incidence of IPBSN injury is less in oblique incision. It's because the course of the nerve, we all know the course is obliquely runs from medial to lateral. So if you give a vertical incision, there is a higher chance that you will cut those nerves. The other important point that we found out was, if you give an oblique incision, the recovery within 1 year is, out of 27 patients, 23 recovered within 1 year, compared to a vertical incision, which indicates that if you give an oblique incision, even if you damage the IPBSN, probably this is some sort of axonotomesis or rather than the neurotomesis. So in case of vertical incision, probably a neurotomesis, and then if it doesn't recover within 6 to 8 months time, it will remain for lifelong, as Silas was trying to say. So the only disadvantage of oblique incision is sometimes if you have to make a really short tunnel, so you have to go up, and this oblique incision may be a hindrance. So you have to subcutaneous release you have to do, so that you can mobilize the incision.
I just wanted to add, the data was also given by Silas. It is definitely less if you put up oblique incision. The other thing I found out, it's not that
Dr. Amit.
Yeah, please, Dr. Arjun. Yeah.
Injury of that infrapatellar branch of saphenous nerve, is there any study done? I have not gone through that.
Yes, we have published in JNHRC journal 2016. If you want, I can send that to you.
No, I mean, what is the long-term consequences, like if it is not recovered?
No, it is just the sensory loss is about the patient's dissatisfaction of sensory loss. But
very
we have
small
also,
area.
yes, small area, but there is no difference in outcome of ligament reconstruction.
Amit, let me say this. My consultant in UK got sued for neuroma pain. Okay. So that is only one experience, not my consultant.
No, that is worse.
No, but we need to be aware we are changing. Yeah. Our way of life in the East is also changing, and our demand is going to change. Yeah. And the patient's demand will change as things.
We can have problematic patients sometimes. So maybe
But
we need to
explain.
We need to explain to the patients that these are the possibilities. That is
You cannot but you cannot avoid IPBSN injury completely. So whatever
even with
incision,
oblique,
whatever incision you give, either you give vertical, oblique, or horizontal, there is some possibility. But with oblique incision, there is a lesser chances of IPBSN injury. Yes.
Can I make a comment here? Can I make a comment? So I think hello. Can
Rajiv, sir,
you hear me? Yeah. So I just want to make, it's already late, I know. I just want to make a small comment. The thing is basically, see, with time and evidence, your techniques have to modify, right? So I was doing a vertical incision. Okay, I was doing a vertical incision, and I found that literature was saying, like Amit and Vivek and all are saying, the literature was saying that oblique incision, definitely the incidence is lower. So definitely you should try an oblique incision, because literature is saying that the incidence of saphenous nerve injury is worse. So that's why I modified to for an oblique incision. And number two, I think when you pass your tendon stripper also, and I've noticed, I've always been used to doing a vertical incision, but these days I've started doing, maybe since the past 2 years or so, I've started doing an oblique incision. I find ease in passing the tendon stripper also. And the hamstring harvest, like how was shown in the video, that was an inverted L-shaped harvest. So initially I was doing a harvest where I was making an incision between the semitendinosus and the gracilis and taking out the individual tendons, just making a longitudinal incision. Okay, and then stripping it out. So I think what my message is basically, according to the evidence and according to the literature, I think techniques should change. Like we all work together in different places. So when we work and we find that a surgeon is showing a different technique which is better, I think you should modify your technique. You must take good techniques from another surgeon also and try and incorporate it. Because
100%, 200% agree.
Yeah, so I think that is because since evidence is saying that, I don't think we should go on with vertical incision. At least you should try I have had very comfortable thing with the oblique incision. And yeah, like Amit said, a little bit of pulling may be necessary, but then we already have very strong assistants who will definitely pull it up very well. I think that's the only issue. Otherwise, I think it's good. The oblique incision is quite comfortable. It's quite comfortable. So that technique of hamstring harvest has changed. Over the years, mine has changed. So that's what I wanted to say. That's all. Yeah, I think we're already late. Thank you. Thanks.
Okay, Rajiv, don't run away. Okay.
Okay, I'm not running away. I was listening. I was late. I really missed Vivek's presentation. I missed Vivek's presentation, which I would have liked to hear.
Half an
The
hour.
others were very good. The very good presentations.
Yeah, this was a very good discussion. I
I've been listening.
Every surgeon has his own way of doing it, and what are your shortcomings. You with what the other surgeon is doing, and you improve your technique. That is why all these forums are here. I have my own way, you have your own way.
Definitely.
What I meant, getting a good presentation from everybody, so that we learn from each other, and
absolutely. Improve techniques, and it'll lead to improve techniques. All these seminars really help.
Us. Thank you to Nijan, who has taken the time and tell us about the post-op protocol. Thank you to Amin and Vijendra for coordinating, and thank you to the presenters, including me, and thank you to the participants also. We have made this very lively. One thing I want to propose as the as here, we are in a very difficult time. Things are really getting into our mind. Reality is creeping in. We haven't had our executive committee meeting for a long time. It's not just a meeting. Getting together and feeling each other's experience, boosting our morale with each other's support. This is the fraternity, you can say. So I request Rajiv, my secretary, to plan a day where we can sit around with, maybe a cup, within your side.
Maybe the content should be different besides Amit.
Just, not the, let's get together.
Amit doesn't drink.
Amit, we'll force him, doesn't matter.
Yeah, I can make the same color at least.
Mocktail.
You don't need anything, it can be your lemon water like this also.
Sairaj Bhai also doesn't